All right. Well, thank you very much. We appreciate that. And I am back in the booth and flying solo for the moment. I don't want people to be worried. Danielle had to step out just for a moment. She may return in just a moment. But I am joined by one of my great new friends, Chris, from the American Hospital Association.
You got it right.
Take a minute and introduce yourself, Chris.
It's a pleasure, Robert. So I'm Dr. Chris DeRienzo, and I get to wear two hats at the American Hospital Association, the AHA. One is I serve as the AHA's Chief Physician Executive, and that means that I get to be a voice within our leadership team from the field. I was a chief physician in hospitals in North Carolina for years before joining AHA, and also a voice for the field. So AHA obviously serves as a voice for hospitals, both in Washington, D.C. and with the media, and sometimes when AHA needs a physician voice, I get to be that voice.
That's fantastic.
Yeah. The other hat I get to wear is as president of our 501c3, and so I know that there's a ton of amazing research. I got to learn a little bit about your foundation here, and so we do some pretty terrific implementation work through the Health Research and Educational Trust as well.
That's fantastic. And I was surprised when I started getting to know you earlier this year. I was surprised to know this is a fairly new role for the American Hospital Association. It's been two and a half years?
That's right. You know, believe it or not, 5 of the AHA's first 6 chief executive officers were physicians.
Okay.
The last one, I think, actually died in office in 1972. So
Okay.
AHA has had physician leaders before, but we had never really scoped a role like this that brought a chief medical officer from within our membership into the association. So that's how this role was created.
Okay.
And my career before AHA was, as a CMO of health system and a CQO of a health system. I'm a neonatologist clinically. And so we wanted to bring that voice in so we could connect with that large and growing segment from within our membership.
Yeah, absolutely. So it gives some stability to the clinician's perspective and voice within American Hospital Association, regardless of what else is going on within the leadership role, et cetera. So that's very interesting. So what are the key issues that sort of you're seeing in the field that clinicians are representing to you, which you're bringing back into the American Hospital Association? What are just kind of the top things that you're focusing on now?
Oh man, there are so many, and I see that we've got 7 minutes and 41
you can
seconds.
Ignore that.
So
I've not been on time yet.
We can definitely, we definitely won't cover them all.
Take as much time as you'd like.
But obviously, this is my first time joining you at an AAMI convening, and obviously, it strikes me that a lot of the concerns that are common within my membership are common within your membership as well. Just walking the floor with Pamela, who's a spectacular CEO for AAMI.
Absolutely.
Listening to the conversations, our members are concerned about workforce. They're concerned about threading the humanity, the thread of humanity into this needle of technology that is ever deeper in the work that we do. And then obviously the march of AI, not only into the operational sphere, but into the purely clinical sphere as well, is one that we see across the board. But one that I think, we are working together on that I think is worth mentioning is the role of medical devices when it comes to patient safety.
Right. And let's dig into that a little bit, because we are starting to work together more deeply on those issues, and AAMI and AHA have worked together in the past, so we're delighted to be doing that again. But what kind of issues do you see? It's a big bucket, right? But what kind of issues do you see sort of being the things that we can tackle in the early going, and especially that the community here, which is so intimately involved in supporting and maintaining, supporting, maintaining those medical devices? What do you think are some of the opportunities where a combined clinical voice and a combined technology voice produce better results than either on their own?
Well, you hit the nail on the head. We've had the AHA Patient Safety Initiative live now for about a year and a half, and that brings 1,800 to 2,000 hospitals together to connect, convene, and catalyze their work around patient safety. And there's a lot that we can do. We've done some superb foundational work just within the scope of hospitals. But one thing we hear from our members is, when it comes to medical devices, we're at the very end of that value chain. We're the ones who are using the IV pumps and the laryngoscope as a neonatologist. And there are things that happen in the course of delivering care that impact patient safety. And man, there's sometimes we wish that we could just have a conversation with the people who design this great equipment that we get to use. And of course, you all are the conveners of the designers. And so that I think is the fertile ground that we're finding together, that there's this shared will, this fit within the market where I have folks from hospitals saying, this is a conversation we wish we could have. And you have folks who work in safety for all the wonderful exhibitors and members here at AAMI who say that's a voice we want to hear.
That's right, and I think that was an interesting thing to me. I've served healthcare in a number of capacities over the years, but still an outsider to the med device space when I came to AAMI 6.5 years ago. And over time, it's been interesting to me. I assumed that all of that connectivity was already in place, and it is, but we hear very strong demand signal from our manufacturers, our servicing folks. They want more. They want more connectivity. It's not enough, and it's. I think today what I'm hearing, it's not fast enough. I hear that a lot with the speed of innovation, especially with AI coming on, and we should talk a little bit about that. But the feedback loop has to work more efficiently and more quickly, and everyone plays a role in that, including our regulatory friends. So I think that's going to be an area of fruitful collaboration. And I know we hosted a first meeting at AAMI together recently, and we're looking to do some more things together in the very near future. So people should stay tuned.
That's right.
They'd like to be involved in that, whether you're a clinician or on the med device side. Find one of us and let us know what your issues are and thoughts are, and we'll get you involved. So let's talk a little bit about some of the other areas. So things like AI. What are you hearing from the field on that? What's the sort of current state? There's so much hype. We just spoke with Laura Adams from the National Academy of Medicine, and I frequently say I don't even like the label AI, because it's sort of like saying, what's going on with computers in the field? It's just so broad, and we have areas where, for instance, in radiology, these advanced algorithms, AI algorithms, have been in place for years, yielding tremendous fruit. But now with all the LLMs catching on and are reaching a scale where they're really useful, it's created a lot of hype. So separate for us a little bit the hype and the reality, and kind of what you're hearing from the field. What are some of the challenges even that clinicians see around the use of AI?
Yeah, I spend a lot of my time, Robert, on the road. I travel about 150 days a year for the AHA, and the most frequent talk I'm being asked to give is around how AI is changing the workflow and the work of physicians. And as AHA's chief physician executive, that's one that I'm pretty good at. And there was an Axios article about a month ago that really sent my mind thinking. It was a wake-up call to leadership, in part because it sort of asks you a really key question. And it's not one I had asked myself, but it's one that once I asked it, I couldn't stop thinking about, which is, and the editors of Axios wrote this for their staff. They're a news organization. Mm-hmm. And so they asked their staff, what are the 3 things that you have to do and do exceptionally well to be a superstar in your job? And then the follow-up question is, how can AI today, not 3 months from now, not 3 years from now, but today, either automate or improve your ability to perform at those 3 things? And so that is a terrific article. I would recommend it to anyone.
Challenge, yeah.
And so when I sat and started trying to think about, as a physician, when I have my doctor hat on and I get to still round about a day a month with the folks at Duke and the NICU as an adjunct, but what are the 3 things that I do that I think are the most valuable? First and foremost, obviously, is care for patients. Absolutely. And so that's providing treatment, but also just being with patients. The second most important thing I think that I do is document and communicate both with the patient and family members and with other clinicians so that people know what I'm thinking. And if that patient, my NICU baby is discharged and follows up 3 days later somewhere, that clinician knows, okay, this is what DeRienzo was thinking. And then the third thing is I've got to secure reimbursement for caring for patients because otherwise we don't have a sustainable way to keep doing that. Absolutely. And so when you apply those lenses to AI, let's just think about where we have seen the most rapid adoption. It's in points 2 and 3. Documentation is no one's favorite part of their job, and so no surprise that we've seen ambient technology take on with such a vigor. And obviously in the revenue cycle, there's increasing application. It's in that first point, though, around the actual provision of care that I think is not only the most regulatory, but also the most sensitive. If you asked a physician, where have we derived a lot of our professional value, it understandably, I think, is in that provision of clinical services. And so as we begin integrating technologies into the actual delivery of care and the decision-making around the delivery of care, no surprise that has been a little bit slower to adopt.
Right. And we're rejoined by Danielle. Welcome back.
Thank you.
Yep, and we're having a great conversation. We've covered a lot of ground. We were just talking a little bit about AI, that piece of
Okay, it's such a
sort of-
redundant topic and theme here.
It's definitely coming up over and over and over
And I
again.
heard you guys outside. Great conversation.
How do we look outside? So I've never been outside when we were in here.
Fabulous.
Do we look good?
You're
Okay.
ready. You're ready for NBC News. That's what they're saying.
I
through
don't
the
know.
window.
I don't think I want to do that. So, what are clinicians most worried about as AI does more and more and more in that first bucket that you're talking about, the actual provision of care, or excited about? Because there's risks and opportunities, and I mean, are there any themes emerging? Or is it so specific to clinical practice area that it's hard to identify commonalities?
Well, I think, as you indicated, AI is not de novo completely new to our worlds, right? I think a couple of years ago, I was speaking at a conference, and 75% of AI-enabled applications were focused on radiology.
Mm-hmm.
And at that time, AI was beginning to reorder radiologists' work lists. And so, I think when I talk to doctors and they ask the question, well, is AI replacing us anytime soon? My answer to them is, well, it kind of depends. I think when I think about the work that we're asked to do today, over the next 5 years, if you're planning to retire, there's components of it that AI will help us do better. And then there are components that are going to be automated. But if I look out 25, 30 years into the future, I really don't have a great answer for them.
Right.
Yeah.
I look at, for example, there was a JAMA study, I think it was JAMA Internal Medicine, a couple of months ago. We're looking at my vintage of physicians. So I've been a doctor for almost 20 years. And if they gave us a standardized test and they looked at doctor performance, and it was, I want to say, I'm not going to get this exactly right, but order of magnitude is right, like 73% correct. Doctor plus AI tool, 75-ish% correct. AI tool alone, 85% correct. That tells me that my generation is the generation who doesn't yet know how to use these tools in a native way. But the folks who are graduating from medical school today, they have grown up with this kind of digitally native environment.
Right,
It's
right.
true.
And digitally native is almost dated now. It's AI native, right?
Yes,
I mean,
yes.
that was of our time. But so now that I have you back at the table, I'd love to ask a question. And this is even a little more, it's not more broad, but it's opportunistic, right? So we've been talking about some very specific topics, but I can't tell you how much time around here is spent discussing the interface with clinicians. Right? How do we support better? How do we help them understand what we do on the HTM side? How do we better understand their needs? And once again, as someone who came to this from a different perspective, I thought, oh, that was already all happening. And I found out there it is, but once again, there's a greater desire on both sides for better communication. So I want to throw it to you for a minute or two, just a question or two, because I told Chris, we're not going to be on time. He was worried about the clock, where there's no way we'll finish on time, and we're not. But a couple of questions. I'd love to hear just the two of you, because you're both leaders in your respective area, discussing that interface between clinical engineering and physicians. What do you think are still the challenges today there? Because once again, folks sometimes say, I don't think they know what we do or how to interface with us, et cetera. But what are your thoughts, and what would you two ask of each other? If you were working in the hospital today and you said, hi, I'm your new head of clinical engineering, you said, hi, I'm a head of whichever practice area, how would that unfold? What would you be doing?
Well, no, I think one of the challenges for us is sometimes I don't think all the physicians completely understand our roles in healthcare. And I think we sometimes can come to a head because we want to make sure that technology is integrated properly. And sometimes I think those decisions can be made without our input, and understanding how it integrates with other systems, the cybersecurity aspect, the interoperability. And now you're layering in AI. And, it has the potential to do so much good, right? But it could also, if it's not executed properly, can also maybe have a mal outcome, which is what we would never want to happen. And I think we're seeing changes too, even in like predictive maintenance and uptime of equipment, because we're really there to serve you. And we want to make sure you have the equipment at the point of care when you need it. And we want to ensure that patients are treated safely within the boundaries of all the IT and standards and policies within the hospital.
Well, I appreciate that. We're obviously here together to serve our patients, and
Yes.
I think that you're being far too kind to doctors in general, so thank you for that. I'm a doctor, so I can be a little bit less kind to our tribe, but I think what I would say is, we're taught in medical school to work through an algorithm that gets us to a diagnosis and a treatment. And so I think that predisposes us to think in terms of this is the solution I want
Yes.
versus the outcome I want to achieve. And so one challenge that I have seen wearing a CMO hat of a health system is having doctors come to IT, clinical engineering, and say, I want to buy this thing.
Yes.
And then we have to transition that to a conversation of help us better understand the outcome you're trying to solve for, or the problem that you're trying to fix that you think this thing is going to fix, because there may be a different way to get there. And I think part of that comes from, again, the way that we are taught to think, but part of it comes from a total lack of understanding what clinical engineering is. No one teaches you in medical school or residency what the Department of Clinical Engineering exists for, what the level of expertise that persists within this team of immense professional. No one teaches you that, so you've got to learn by doing.
Yeah, and I think that's the thing. There's just, I walk through hospitals every day, and they're like, "Oh, I didn't know you existed as a department." And no matter how much you feel you advocate for it, and I think you're spot on. It's a physician that says, "I want this because I want it," and then it's like, well, why do you want it, and what are you trying to do, and how can we help you? And I think, and you always have those situations where I'm sure you've seen where you walk down the OR and there's like a new robot there that you had no idea that someone bought in the OR, and you're like, oh my gosh, like how do we integrate this in? And I think throughout the ecosystem of healthcare, you have, I think the physicians tend to do that more. I think you're spot on with how you described yourself. But then you have nursing that sees the technology as an obstacle, right? Nurses don't go into nursing because they love technology. They go into nursing because they want to help people. And when you're trying to swap out the physiological monitors or the infusion pumps, I see there's a lot more apprehension at times because they love what they're used to using.
Well, I think you're hitting on a key point, which is healthcare is and will always be a uniquely human experience.
Yes.
And if I look back over the last 20 years, I think one of the mistakes we've made is failing to thread the needle of technology with that fiber of our own humanity.
Yes.
And I think about the earliest evolutions of EMRs and whatnot, and my gosh, we pulled ourselves away from the bedside so much. That's changing.
Weren't even
now.
looking the patient in the eye
it's
anymore.
True.
Yeah.
And you say that. My mom was an ER nurse, and that's how I came into this. I loved healthcare, but didn't want hands-on patient care. And I remember she worked at a small local ER, and they were converting to get an EHR away from paper. And she's like, I might need to leave nursing. This is going to be disruptive. I don't know how I'll do it. I can't use a computer. And, it's just crazy how now you would never, if a doctor or nurse came in and said, I don't want to use a computer, that seems like a crazy statement. But you think of that with new layers, with AI, people being skeptical about it or not really understanding it. Or we had Laura talking about the AI code of conduct, ensuring that, we're keeping that dignity in healthcare.
One of the central, dignity of the human component of all of this.
Because at the end of the day, we're the path to the patient. We're all there for the same reason, which is patient care, and we just want to work together to make hospitals safer, more efficient, and better. And that, because people come into hospitals during their most vulnerable times, and it's because of people like you and the instrumentation there that they have positive outcomes. Because people look at, when I first took this job, people were like, how can you work in a hospital every day? It's so dismal. And I said, well, hospitals are also places where people go to heal. And people don't often think of that.
Right.
We are a necessary place.
Yes.
Right? I think about hospitals as both a reflection of and a pillar within our communities.
Mm-hmm.
And you're exactly right. I will say one interesting note about paper records is the generation of us who grew up having to document on paper we're aging out of the workforce.
Mm-hmm.
And so, but when you have a cybersecurity incident, we have two spectacular team members at AHA, John Rigi, who's retired FBI, and then Scott, who is retired Secret Service. They talk about how it's those folks who remember what to do when you have to go to downtime. And so when you don't have them in the workforce,
we can't become over-dependent, can we?
You got to relearn paper, right? So it is sort of this backup and redundancy. But I guess what it really all boils down to is, as the workforce challenges that we face persist, and to be clear, solid evidence suggests we will never recruit our way out of this workforce crisis. We need to increasingly find ways that our technology can support people to do the things that only people can do in healthcare. And that's what makes me so excited about our partnership with AHA and AAMI. It's why I'm so excited to get to walk the floor here for the first time and hear about the conversations that are happening within the world of medical devices. Because if that's going to happen, this is where it's going to start.
Absolutely. And it's
fantastic.
our honor to have you here today. And we feel
Absolutely.
so special to have you on the show. So thank you for being part of it.
Getting to know leaders like you who are working the problem makes me optimistic.
It's
So
a privilege, y'all.
It's a wonderful
Yes.
thing. So thank you very much for being with us, and we look forward to continued collaboration. So people should sign up for our newsletters.
Yes.
Because anything that we're doing with AHA, we're going to be putting out information, trying to get as many folks as we can involved. So
Wonderful.
And thank you for all you do to keep patients safe and all your work at the AHA.
Thank you so much, y'all.
thank you.